Yeah, thank you for inviting me to give a talk. I realize that I might be slightly an outlier as the speaker of this, so I will start by briefly introducing my lab's work and my work to you. I'm an AI researcher and cognitive scientist. I run the Human AI Interaction Lab at Seattle and Simon Fraser University, where we build systems that model socio-emotional behaviors using AI techniques to create better interactive technologies and also use them to understand and evaluate human behavior by modeling them in computational systems. I specifically work on effective computing and modeling complex human behavior such as empathy, perspective taking, and theory of mind. In the past few years, I worked on a number of projects, including virtual agents and VR, AR technologies with biosensors and tackling on gender stereotype issues in agents and also pedagogical agents and mental health applications. Today, I will focus on how we can use AI-powered socially interactive agents to support healthcare, mental health, and well-being in a variety of ways. Is everything still okay? Can I see maybe a thumbs up? Everything looks fine. Okay, thank you. So socially interactive systems are computer and AI-driven technologies that can interact with a person using natural communication methods such as language, speech, gestures, and display socio-emotional behavior using these AI models. And these systems can take form of chatbots, you might be familiar with them, voice agents, virtual avatars, or robots. And in the past 10 years or so, AI technologies have become very powerful, and we now have more bigger and more accurate models that can handle a lot of data and support real-time interactions. And this led to the emergence of interactive systems that allow not only fast, but also natural, effortless interaction that we were aiming for. And new technologies emerged in the past decade that turned computers from mere tools to assistants, educators, and even companions. And given its importance and cost, healthcare represents a significant opportunity for automation and the use of socially interactive systems in particular. And for example, countries that have severe shortages in resources can significantly benefit through the relatively low cost of automation. And even most advanced countries can benefit since small improvements in health outcomes or cost reduction can yield large returns when scaled to a population. For example, there exists a well-documented need for mental health services in Canada. There's a limited access to services, lack of caregivers, especially for vulnerable populations, long wait times for both primary and psychiatric and community care. These are like constant issues that we are facing. And there is also a growing number of older adults and lack of caregivers globally. Furthermore, a high percentage of nurses and clinicians reported considering to quit their job due to burnout, which is increased issue with the pandemic, although this has been apparently an issue long before that. And lastly, there are barriers to accessing healthcare services, especially a lack of knowledge on where and when to seek help. There can be a fear of stigma with mental health issues, for example, or substance abuse issues, and there can be cultural or language barriers that can affect certain demographics. So with this background, interactive AI systems can provide unique affordances in automating aspects of healthcare delivery and also help the human health provider, especially when care is in the form of information or guidance to be delivered. These systems are never intended to replace human healthcare providers, which is a misconception, but rather automate the routine parts of their work. So maybe they can focus their time on exceptional cases, or maybe there are patients that they cannot reach, or patients that cannot access to these services. So these systems can provide help with perfect consistency 24/7 to every patient, regardless of their location, can be repeated as much as needed. So can be much less costly in remote locations, for example, where help is not accessible. Socially interactive systems can not only provide these instrumental delivery of medical information to patients, but also social, emotional, and relational messages, such as compassion, empathy, that more conventional digital media lacks. And these can be personalized automatically and continuously. And these systems have been shown to have benefits in multiple interventions and use cases. I will now go over some examples where some of these systems showed success. I will start with modifiable health behavior, such as physical activity, for diet, smoking, which accounts for a big chunk of preventable healthcare issues. Addressing modifiable health behavior with interactive AI systems such as virtual agents and chatbots has been the target of many studies and interventions. The agents can be developed to perform screening, brief interventions, and referral to specialty treatment after being assessed. And these systems can be successful in being motivational and also tracking healthy behaviors such as diet modification, increasing the physical activity, managing substance abuse, or maybe promoting medication adherence and managing stress. So, and this can be applied for both young and older adults and people with varying health and technical literacy. They have been also used to automate cognitive behavioral therapy and motivational interviewing techniques, and were seen to be successful in reducing stress, anxiety, and depression in people. And these systems can be coupled with also sensors to aid with monitoring healthy behavior, personalized interaction, and managing chronic conditions. So, for example, heart rate sensors can be used as alert systems and detecting anomalies, which can be crucial in timely and help and support. And some of these systems can be used with also commercially available smartwatches and smartphone-based tracking systems. With the improvements in AI models, we now can evaluate, for example, many things such as eye skin health with cameras, daily activity, fall detection, and sleep behavior with GPS and gyroscope, cognitive functions through speech anomalies using the microphone, all of which can be currently accessed in most of our like smartphones. And nowadays, there's also a lot of improvements on edge computing, which means the data that is collected does not necessarily have to leave the device to be analyzed, which can reduce the privacy concerns because healthcare data is like very important. Oops, I went over too quickly. Oh yeah. Moreover, natural interaction methods such as face-to-face conversation by using just a camera or conversation using just a microphone can still allow us to pre-screen or conduct surveys and interviews with users. For example, in our lab, we are using embodied conversational agents, which is like the avatar you're seeing now on the screen for this specific purpose, that are equipped with socio-emotional behaviors such as empathy for pre-screening and education. We use this specific agent for conducting patient health questionnaire, which is used to assess the depression severity in intake scenarios. And mostly the survey is conducted as a pen and paper method, and people who have concerns need to be usually going to the clinic to take the survey. But using this agent, that this can be done in a conversational manner, in online from anywhere, from their computers and in like their smartphones. And due to its social capabilities, users can receive real-time, face-to-face feedback and suggestions on how to cope with their issues. So I'm going to attempt to show an example for you. I hope this is going to go well. This is going to be a video example of an interaction with one question and patient health questionnaire. I will only show one question, interaction with a student. The student was just acting here, but this is just to show you as an example how the interaction looked like. Please let me know if you cannot hear anything.
How many days have you had poor appetite or been overeating?
You know what, a lot of the time, I don't even have the energy to eat or cook. Sometimes it's even hard to eat rice.
I'm so sorry you feel like that. It is important to keep a healthy diet. I can contact you to the counseling service at school to get you some help on this.
That could be helpful.
So this is a very short, brief example of how like empathic and social feedback could be given. Okay, I get something in the chat. Did you not hear? Okay, you can hear. Okay, great. Here we were primarily evaluating the empathic behavior of this agent, and we did not conduct a clinical study, but our results for the study we did with the SFE students and online general population show that the agent was preferred still to pen and paper survey and was found useful and engaging. I'll try to move on to the second. Okay, great. Another potential use case for these systems is to support healthy aging. The average age of the world's population is steadily increasing, and older adults prefer to maintain their independence and high quality of life as long as they can, and they might need assistance to do so. There is an increasing number of research nowadays focusing on supporting healthy aging with AI-powered interactive agents. Some of these agents could assist in daily tasks, reminders for medications, and access to information, but also maintaining remote contact with friends and families, acting as companions themselves, assisting in physical and cognitive activities, and supporting mental health. And there is some evidence in older adults preferring physical systems such as robots over virtual assistants, which is interesting, especially when it is acting as a social companions. However, the cost and personalization of these systems can be an issue, and it can be limited. Oh, sorry. Yes, related to this line of research was my work with the Digital Health Circle and the Age Well initiative, where I worked with Professor Silvia Moreno. Our idea was to support social prescribing, which can be defined as a way of linking patients or general population with sources of support within the community to help improve their health and well-being, and use as preventive care as well. Which is not limited to medical health, but can also be, for example, educational, social, or it can be artistic activities. What we proposed here was to create a collaborative creativity network to assist, like increase social interaction, but also increase more creativity activities among the elderly, powered by interactive agents, where older adults could learn about, for example, different painters, their styles, and as well as use that knowledge to create stylized portraits of themselves with generative AI and share these with each other for prompting social connection. Unfortunately, by the time we started this research, the pandemic hit, so we could not move forward with it, but it is a line of work that we really want to continue. A similar industrial collaboration I made through my text was with Curatio. It's a Vancouver-based company that focuses on social health prescription. And together with Professor Steve DePaula at SFU Ivy's lab, we focused on creating a conversational agent, or a chatbot, you might say, for assisting and educating patients about chronic conditions, conducting surveys, and connecting them with others with the same health condition. So it was designed to be easily accessible through mobile networks and has been used in many countries globally. This brings us to one of the most successful application areas of AI-powered socially interactive systems, which is education. Interactive systems developed for educational purposes are called as pedagogical agents, and these systems can be used to provide healthcare information and psychoeducation to the masses. And similar to the previous applications I showed you, these systems can be in the form of chatbots, voice or virtual agents, or robots. One thing to bear in mind here, though, is health education is considered as necessary but not sufficient to achieve behavior change. So these systems are usually thought as being used in conjunction with other counseling techniques, like aiding the actual healthcare practitioner to succeed in the long-term behavior change, being available there 24/7 to answer any questions, for example, the patient might have. For example, one study showed that after interacting with a virtual hospital discharge nurse, more patients reported to prefer receiving instructions from virtual nurse compared to the humans. They reported, when asked why, they reported not feeling rushed with the agents the way they felt with the doctors in the hospital, and they could ask repeated questions and receive more explanations. And the results seem to hold even for patients with low computer literacy. And other studies, for example, showed successful results in psychoeducation, educating patients about PTSD and depression. And here, robots are also found to be successful in genetic counseling and education case, which seem to have more success in patients with low health literacy. This is an important aspect that we see repeatedly, that we see the positive results in low health literacy as well as high, and low technical literacy as well as high. And we seem to have this benefit constantly, which is a nice thing to see. And in my lab, we recently initiated a collaboration with Dr. Xin Tong at Duke Kunshan University on education parents of children with autism. In Canada, for example, it can take a very long time for a child to get a diagnosis and the family to access the counseling information they need. Waiting times can be often over a year, which can be very critical in a child's development. So with this collaboration, we are planning to create a mobile AI-powered agent that parents can start learning from and asking questions to help them through understanding their and their child's needs and understanding the condition, maybe removing some misconceptions. And we will also be having a workshop soon on designing AI interfaces for children with special needs as a part of the interaction design and children conference this June in Northwestern University. So we would love to see you there and participate in the discussion. Before opening up to the discussion, I want to also briefly mention the challenges and issues the field is facing today. Firstly, as you may have noticed, this is a relatively young research area, and the capabilities of AI models have very recently had increased the efficiency of deep learning in the last 20 years or so, due to the complexity of the signals that needs to be processed in these interactive agents case, such as the human language, like face recognition, emotion recognition, social behavior recognition. Interactive systems have just in the past few years actually got good enough to be applicable for general use, and that can be used more than just like a simple use case. And because of the consequences of system failure that can be so high in medical applications, these models need to be highly accurate, and we need to keep training these models. So there has to be a human in the loop component where we can detect the edge cases that can be evaluated by humans while we are developing the systems constantly. Another issue, which could be also affected by the recency of the field, is that most studies report short-term effects, and there are very few evidence on long-term behavioral outcomes. So it is not clear that what we are seeing today, that what I showed you, if it's most likely a novelty effect, or whether we can achieve long-term effect adoption of these technologies, and to be taken seriously by the medical industry, and actually to be considered as a routine care or being used in the healthcare. These technologies might be really evaluated rigorously in large-scale trials that take a long time to conduct, and we need to achieve, for example, significant results and have meta-analysis for multiple studies before having the adoption, and we are not there yet. There are also ethical concerns about user privacy and sharing of the personalized information, as I mentioned. Although there are on-edge solutions right now, meaning the data does not need to be shared, and models can be computed by the devices of the users in some cases, and like some sensors. We still need to share this data with the clinicians, and we need to have the human in the loop element. We need to figure out how this is done, and we need to educate the users accordingly as well, which is very critical. Finally, we actually don't have the abundance of data in healthcare cases that we have, like in, for example, large language models that we have right now, which you can just scrape the whole internet. So that means that the models can be susceptible to bias too. And there are ways to mitigate this, but as far as I know, there hasn't been any studies done to examine this in the field. And moreover, despite the positive outcomes, the attitude towards AI systems and agents are facing challenges, especially with the ethical concerns I mentioned today with the AI, of the acceptance of by the masses might be like an issue for the long-term adoption. So yeah, that's what I prepared for you. I hope that was interesting, and I'll be happy to get any questions from you now.
Just give me 1 second. Okay, we'll just do it that way. So she can only hear you through this microphone from the computer. So you'll just have to repeat the question to her. Okay.
Yeah, sorry to create this extra logistic challenge.
Yeah. You can hear us okay from here?
Yes, I can.
Yeah, okay.
Thank you, Dr. Yalçın, for such a thought-provoking talk. We're going to open up the Q&A now. And because of our configuration, I'm going to repeat the questions for you just so that you can hear them nice and clear.
Thank you.
I'm going to open up the floor now for anyone who has questions.
Yeah, thank you for the talk. I'm just curious to see your thoughts on anything like this, like AI-based interventions for like crisis de-escalations or crisis like call centers. Especially like, for example, you find known to respond better to text-based crisis centers sometimes. So whether they're text-based or like voice-generated mental health like interventions like that.
So I'm going to repeat the question to the best of my ability. So an audience member is asking about the use of AI in crisis de-acceleration. So do you want to elaborate a little bit so I can repeat the last part of your question? Yeah. For mental health, so dealing with crises in mental health, the role of AI in those contexts.
Yeah, so currently, as far as I know, there are no like direct use case studies for because of the like issues with like the problem with the failure rate, basically, that are done like in the clinical settings. I think we are not there yet, honestly, but these systems, in my opinion, can be used to as a pre-screening process. As I mentioned, we still need to have the human in the loop currently to be able to do so, because we still don't know anything about, for example, the biases. If like someone called the call center, let's say, but the language model that you were using wasn't equipped to understand a certain accent, then that calls fall through. The result of such a thing is catastrophic, right? It can result in someone losing their life even. So I don't think we are going to be there in near future unless we solve these bias issues, and rigorous research and human in the loop processes are needed for us to be confident enough to use these systems in such like emergency situations. Does that help you answer your question?
Thank you. That was perfect. We're going to take another question from the audience. Go ahead, Randy.
Thanks, Neely. Great talk. Quick question about what you think are, I guess, the most promising applications for AI coming up and the most difficult applications for AI coming up.
So what are the most promising applications coming up for AI, and what are the most difficult or challenging applications for AI, in your opinion?
I think the most promising is in AI in general can be like detecting anomalies in medical data in like a very fast and accurate way. But in agents that I was talking about today, I still think it's mostly education because of this repeatability and ease of access. Like people can just ask the questions over and over again, ask the questions in different ways, and they actually really like and find this comfortable, like from what we see from a variety of studies. I did not conduct these studies myself, but the studies that I cited, I found these two areas as the most promising. And the most challenging one is emergency care, as I mentioned previously, because of like the like many issues that we have there right now. Well, of course, like this is just a 5-second thought process. Maybe I'll come with a more smart answer and then come back to you.
Okay, another question.
Thank you for the talk. I was wondering how population heterogeneity can be taken into account when designing this kind of AI systems. So, for instance, in the context of preventive aging, so how can this system take into consideration like the profile or types of profile of the aging population, so that the responses of the agents can be most effective?
Yeah, so we have a question from the audience about incorporating population heterogeneity into the design of AI systems, and specifically the example that was given is in the context of aging. So could you speak to that a little bit? Did that capture your question? Okay, great.
Can you maybe provide more detail, like explain the question a bit more?
Sure, yes, just give us one minute.
Yeah, so for instance, in the context of cognitive aging, if we take modifiable risk factors such as lifestyles, right? So we can have a group of factors that can be maybe leading to a positive outcome for the population and a negative outcome for other population. So I was wondering, like, how in the design of this kind of systems we can take into account these issues.
So in the context of aging, thinking about modifiable risk factors, does that sort of capture?
Yeah, this is just an example, but in general, so if we have, let's say we have a treatment, right? And consider population. So the treatment can be made effective for a population and not another one.
Yeah.
So same here, if we present the system to the population, so how the AI system provides responses to, for instance, inquiries of the people, so it can be different, right?
Yeah, and I think this is a theme that generally came up today, the idea that there's variability in responsiveness, and how does an AI kind of take that into account, that there's heterogeneity in how one responds to treatment, causes of diseases, and how we sort of fold that into thinking about AI systems.
Yeah, so as I mentioned, one of the downsides of this like research right now, like the issues and challenges we had, mostly not downsides, is that the studies are generally conducted in specific locations, like mostly in North America, and for example, and it's not conducted with a large population enough so that we can like collect enough data. And as I mentioned, like in AI systems, it is really important for you to have enough data to generalize and like to learn from, and to have, for example, the demographic information included into the AI model, so that the model itself can learn like different parameters and how it can change. And we are not in virtual agents, for example, we are not unfortunately there yet. But one of the good things about like the new AI models that are coming up is that they allow this continuous training and being able to be personalized. And if we can achieve like this continuous learning and human in the loop process, I think we can better answer to different population needs and understand better to like to the extent of how much we need to change like the AI system. But in order for us to do this, we have to start with these not that critical, maybe health intervention, like maybe, as I said, educational technologies and so on. Does that help answer your question? Sorry.
Thank you. That was a great question.
A fascinating talk. My question is more on the regulatory side. In counseling, there's licensing bodies and groups to make sure that feedback provided meets a certain standard. And it seems with AI, like this, the barrier to entry for anyone to put together some sort of application is quite low. Is there any sort of nascent regulatory or licensing bodies getting involved to make sure that this is done to that high level of ethical standard?
So the question is about thinking about kind of regulatory bodies and licensing. So are there any kind of regulatory bodies that are getting involved either on the Canadian landscape or more broadly to kind of regulate what's happening with AI?
Yeah, not right now in terms of like the healthcare, because it's like the clinical applications are not even applied for like broader public use, and it's still like small scale studies, small use cases. We are currently not there yet. But the AI research in general, not the interactive systems, I'm talking about more general AI research, are continuously thinking and talking through these issues. And I'm very hopeful that soon we are going to have like these conversations in virtual agents and healthcare as well.
Thank you so much for the talk. I think that's a really timely topic, especially in the past few months, even based on the discussions around AI and how it can be used, both for better or worse. My question, I kind of have two questions. My first one relates a little bit to the initial question with regards to crisis. What kinds of safeguards are in place? So, for example, you know, people are seeking this information for a reason, right? They might be in a state of mental distress, or you know, they might have a physical health issue. Is there a way to kind of monitor when additional intervention from like a human or from a medical professional or mental health professional might be needed? That's my first question. Do you want me to wait for?
Yes, please. Thank you. My working memory is not the best. Okay, so the question is about kind of going back to one of the earlier questions about crisis management. And the question is really about the safeguards that should or could be put in place so that we can kind of monitor in those kinds of situations where maybe the AI isn't doing very well, that where interventions can be put into place. So just sort of related to one of the earlier questions, but kind of maybe more forward facing in terms of how we best approach doing that in terms of really protecting people who are using AI and are so vulnerable in those crisis situations.
Yes, thank you for this question. And one of the things we can currently do with these AI systems, and for example, I'll give the example of the natural language processing, is that you can get like accuracy score or like the probability of the answer being understood along with your model's like answer. And when you have that, you can have like a very high threshold that you can say, if you are not 92% that this question, what this question means, and if you cannot like categorize this question, then immediately send it to like the human. And that is what I mean in the human in the loop process. And this can be done fairly efficiently without like losing the contact with the person interacting. And it can be done fast, where the human only sees and hears these edge cases, so that you can be efficient. If the same question has been asked before, for example, you can automate those. But at the same time, if the model is not really sure, instead of giving like a random generative answer, which they can do, and sometimes like people like it if you're in a creative application, if you like to like discuss and talk with the agent, but like for serious medical applications, then you can immediately, for example, send it to or connect it with the human, which can like see these edge cases, and then you can continuously train this, right? Then the agents saw that question, which they didn't know before, and how to act and how to interact. And on top of that, this is like one way to make sure you always improve and you don't like, you kind of try to reduce the failure. And the other thing you can do is the regular checks of and the statistical analysis of like the acceptance, the user satisfaction, and like asking the user, did I understand you correctly? Things like that, maybe to incorporate that into the, so that these are the things that can be autonomized. And long story short, you have to have humans in critical places currently to be able to like respond to these like important health and education use cases. Did that answer your question?
Yes, thank you so much. There's a second part or a second question coming.
You actually answered it already. My question was going to be, like, is there a way for clients to kind of give feedback? So for example, like when I contacted customer support and there's an AI on the other end, sometimes they don't always address my question. And I'm like, no, that's not what I'm asking. And then it just continues loop of not being helpful. And so my question was, is there a way for clients to give feedback to say like, no, you're not to the AI or whatever, like you're not getting it. Yeah. Thank you so much.
Yeah, so the question asker was just mentioning a curiosity about whether there's a way for clients to give feedback to the bot, and you sort of already answered that question in your last response. I'm going to follow up on Karina's question a little bit, the first question. I'm just really curious, like one thing that's maybe different about a human versus an AI, and I'm not sure if you mentioned this in your talk, is the uncertainty that we convey through nonverbal cues like our intonation. And so I'm just curious whether that's something that could eventually be incorporated into AI bots.
Well, yes, that is a very active line of research, and we are not doing as well. For example, we also cannot detect sarcasm that well. For example, these like nuanced, more complex social cues that you convey, like for it to like not actually mean what you're saying, but maybe doing sarcasm and figure of speech. These are still like in the large language models that we are seeing today, it seems like they are a bit better, but other social cues, like as you mentioned, intonation, are still following suit, but there's a lot of good research coming up in this area, but we are not there yet.
Dr. Yalçın, thank you for a really fascinating talk and a final discussion today.